تمام هلا.
ماشي. Okay, so today we are going to talk about esophageal disorders. Uh, it's quite interesting topic. Uh, it can be very simple and it can be very complicated. So I'll try to make it as simple as I can. To start with, we have to know what we are talking about, the esophagus. It's just a tube. It's a muscular tube. Most of the muscles are smooth muscles, and it's the whole of the tube is a smooth muscle, except this area just near the upper esophageal sphincter, where smooth muscles and skeletal muscles joins together, and then above it becomes all skeletal muscles. So most of the disorders of the esophagus is related to smooth muscles. Um, so it's related mainly to the lower part of the esophagus. Of course, it connects the hypopharynx and the oral cavity with the stomach, um, and it is used to actually bring the food from the oral cavity into the gastric lumen. It has got an upper esophageal sphincter, which is this one, and it has got a lower esophageal sphincter, and in between is the esophageal body. The esophageal body has a specific characteristics. It has a propulsive movement upon swallowing, which will propel or push the food down the esophagus into the stomach. The lower esophageal sphincter prevent the flow of gastric contents backward, and in addition to the movements or the propulsive movement or the peristalsis, there are also the crust of the diaphragm also enhance the integrity of the lower esophageal sphincter. The symptoms presentation can be very simple. Most of the patients may present with dysphagia, that's difficulty in swallowing, odynophagia, that's painful swallowing, sometimes chest pain, non-cardiac, of course, heartburn and regurgitation. These are two cardinal symptoms which are related to reflux. Diagnostic tools that can be used in investigation of esophageal disorders, including imaging, and that is barium swallow. Sometimes we can use a CT scan with oral contrast. We can use endoscopy. That's what we do at the gastrointestinal investigational unit. We can do motility study or manometry. We can study the esophageal pH. So to monitor whether there is any reflux or no, and more recently, we can study something called the impedance, which is the consistency of the bolus and the direction of movements of the bolus. So this is a simple barium swallow. We give him a barium. We give the patients a substance called barium. Upon X-ray, it appears whitish in color, and it line the esophageal wall. As you can see here at the lower end, this is the area of lower esophageal sphincter. There is a small ulceration and smooth peptic structure down here. So we can diagnose easily stenosis structure, whether benign or malignant. Sometimes we can diagnose achalasia and other disorders by using this modality. This is a picture of the gastroesophageal junction during endoscopy. You can see color difference. Here is a little bit whitish. Here is a more dark reddish in color. Now this is a specialized gastric type lining, and this is stratified squamous epithelial lining of the esophagus. And this area, which is slightly irregular, this is called the Z line, which usually we can find it at the lower end of the esophagus at the gastroesophageal junction. It marks usually the end of the esophagus and the beginning of the stomach. You can see the uppermost gastric folds in this area. Okay, the 24 hours esophageal pH monitoring. We pass a catheter through the nose. It has got a sensor, and we place the sensor 5 centimeter above the lower esophageal sphincter, and we connect it to a special machine where it measures the pH continuously for 24 hours. And then if the level of acid exposure is above the physiological one, we call it reflux disease. So gastroesophageal reflux disease, probably this is the one of the most common disorders worldwide. As simple as this: some of the gastric contents flow backwards into the esophagus at a rate more than the physiological one. Now remember, the gastric pH is low, pH probably 2, 1 or 2 or 3, so it's acidic, it's highly acidic. The esophagus is not designed to tolerate high acidic contents. So when acid comes in contact to the esophageal mucosa, it will cause inflammation and sometimes ulceration. So excessive acid exposure into the lower part of the esophagus will cause inflammation, and this is what we call gastroesophageal reflux disease. Physiological reflux episodes occurs normally in normal individual. If you eat a lot postprandially, they are short-lived asymptomatics. This is a very common disorder. Between 10 to 25% of the population reports reflux episodes, and it happens because of failure of anti-reflux mechanism. So, as I said, the major anti-reflux mechanism is the lower esophageal sphincter. If there is incompetence here, then there is an issue which will lead to flow of gastric contents backward. For example, hypotensive lower esophageal sphincter, certain foods like caffeine, chocolate, certain medications like nitrate and calcium channel blocker will decrease the pressure in the lower esophageal sphincter. Smoking as well. If there are anatomical disruption of the gastroesophageal junction, like if the patients have hiatal hernia or increased intra-abdominal pressure, like for example in a pregnancy, will result in reflux disease or impaired physiological function of the lower esophageal sphincter. I told you earlier that the esophagus has a characteristic propulsive movements called peristalsis. So if there is an issue or impaired in peristalsis, then there would be impairment in acid clearance in the esophagus, and occasionally there may be impaired defense against epithelial injury. In rare occasion, hypersensitive esophagus is a specific condition in which a physiological amount of refluxate may cause systemic symptoms in patients. The two main features of reflux disease, heartburn and regurgitations. A majority of patients will present in such a way. In rare cases, you may find patients with dysphagia, chest pain, nausea, hoarseness, and cough, wheezes, asthma-like symptoms. But the main or the two major symptoms, heartburn and regurgitations. Now, because uh, because there is excessive acid exposure at the lower esophageal sphincter, um, the patient's liable to develop certain complication, because acid will cause inflammation, ulceration, and if this ulcer heals, it will cause stenosis. So it may cause esophageal stricture. It may cause something we call Barrett's esophagus. Barrett's is a name of a surgeon who described this condition. It means there is changes in the epithelial lining of the lower part of the esophagus. We will describe it later on. Cancer, adenocarcinoma is one of the complications of um, um, excessive reflux disease and Barrett's esophagus. Chronic laryngitis, exacerbation of asthma, and decreased quality of life. Sorry. How do we diagnose? We have lots of tools to diagnose the patients. None of them is 100% specific. However, in young patients with typical symptoms and short presentation, we may treat the patients without even any investigation based on his symptoms. Now, in other cases, we might have to do certain investigation. For example, barium swallow with the Trendlin-Bear position will show us backflow of refluxate from the stomach into the esophagus. Endoscopy may show inflammation and ulceration, but if it doesn't show inflammation and ulceration, it does not exclude reflux disease. 24 hours pH monitoring. If more than 5% of the time less than the pH of the lower esophagus less than 4, then this is positive results for reflux disease. Laryngoscopy may show us inflammation in the upper parts of the larynx as a result of reflux disease. And impedance, motility with impedance. The impedance will show you the direction of flow of the food inside the esophagus. So it can show us whether there is a reflux disease above the physiological rate. Now, how do we treat lifestyle modification? The most important thing is weight reduction. Reflux is strongly associated with obesity. Of course, stopping smoking will help. Good night's sleep will help. Reduction in the food that contain oil or fried food, especially at night, even fresh juices at night, all will help. H2 receptor blockers can be used for symptomatic controls in a very mild disease. The mainstay is proton pump inhibitor. Which is the best one? They are all good medications, so anyone can be used. The best one is the cheapest one that works with the patient. And there is a room for surgical intervention if the patient does not want to take medications and he is unlikely to change his lifestyle. This is an example of endoscopic inflammation, reflux disease. This is small area which is inflamed, and actually probably there is a small ulceration in this area. Now, we'll talk about Barrett's. Patients with long-standing um, gastroesophageal reflux disease, um, as I said, the normal lining of the esophagus is stratified squamous epithelium. Now, metaplasia occur in this epithelium, and this type of epithelium is changed into columnar epithelium. Now, the thing about this columnar type of epithelium that it poses a risk for adenocarcinoma, which is more than 30 folds above the general population. However, the annual cancer incidence is still small, very small. So how do we diagnose Barrett's esophagus? You need endoscopic picture. This is the stratified squamous epithelium shown in purple color, and this is gastric mucosa, and this is metaplastic epithelium. So the gastroesophageal junction is here. If there is a columnar epithelium above the GE junction, then we are talking about Barrett's esophagus. It needs to be biopsied and to confirm the diagnosis with the biopsy that should show intestinal epithelial cells. This is endoscopic picture. This is normal esophagus. This is normal esophageal mucosa. This is the lower end of the esophagus. This is the gastroesophageal junction. Please note that these are gastric folds, and this is esophagus. This is stratified squamous epithelium. Now look at this picture. The stratified squamous epithelium is in this area, but look at this area. It's all replaced by salmon-colored epithelium. This is columnar epithelium. This is typical Barrett's esophagus. So, so this type of changes in the lower part of esophagus is associated with increased risk of adenocarcinoma. There is a Bragg classification. So we measure the circumferential height of this epithelium. It's a 3 centimeter here, and we measure the maximum length of the tongues of epithelium. It measures 6 centimeters. So we call this C3, circumferential 3, and M6, that's maximum length of the esophagus, and we call this Bragg classification. How to treat Barrett's esophagus? First of all, it's the results of gastroesophageal reflux disease, so we need to treat gastroesophageal reflux disease. Then, because this epithelium or this lining poses a risk for cancer or adenocarcinoma, then we have to keep the patient on a surveillance program for dysplasia. If we found any dysplasia, then we need to do probably endoscopic therapy for dysplasia, like endoscopic mucosal resection or ablation with photodynamic therapy and other modalities. In rare occasion, we might need surgical esophagectomy, but this is not the common practice at this moment. So mainly endoscopic treatments for dysplasia. Now, eosinophilic esophagitis, it's simple. When you have increased number of eosinophils in the esophageal mucosa, that's more than 15 per high power field, and associated with certain symptoms, the main symptoms, dysphagia and food impaction and refractory heartburn, occasional abdominal pain. So the main symptom is really dysphagia. Why does it happen? So this is antigen mediated immune response um, will result in esophageal dysfunction and characterized by eosinophil infiltration of the mucosa. It is strongly associated with allergic condition. Again, the main symptoms are difficulty in swallowing. That's dysphagia. And not uncommon presentation as food impaction. This is how it looks endoscopy. You look at this, you will think it looks like a trachea, but it's really esophagus, and we call this endoscopic picture trachealization. Sometimes furrowing, and when you take a biopsy or try to dilate, the mucosa splits easily. Treatments. We give PPI if the patient have reflux disease, or probably I give all of them PPI. Topical glucocorticoids, the same steroids that we use for asthma, but we ask the patient not to inhale it, but to swallow it, and it helps a lot. If the patient has dysphagia, then endoscopic dilatation may help him, and then diet exclusion therapy. It has been found that exclusion of certain types of food in patients' diet may help to improve this condition. Corrosive esophagitis. كلنا عندنا في البيت خزانة تحت المجلة. It contains strong alkaline or acid citrus أو فلاش تبع الحمامات. بليز يعني اعملوا لوك إلها، تجيب اعملوا لها مفتاح، حطوا لها قفل، اعملوا اللي بدكم إياه. Because treatment of this condition really up till now is frustrating. Now, upon ingestion of this material, this will cause severe ulceration, and subsequently this will end up in fibrosis and then stricture formation. And that's the endoscopic picture that you will probably see after corrosive ingestion. This is very narrow, and it will require frequent dilatation. Patient will continue to dilate most of their life, and actually in the esophagus it poses a risk of cancer developments after prolonged period of time. So prevention is the best. Zinkers. So Zinker's diverticulum. It is a false diverticulum. Actually, it occurs at the posterior pharyngeal wall or hypopharyngeal wall. Look at this area. Look at this diverticulum. So this is Zinker diverticulum. It should be continuous like this. So what happens? Some of the food will come in and sit in here. This will cause halitosis, sometimes dysphagia, difficulty in swallowing. And what we do, there is two modalities to treat this condition. Either we resect it surgically, or endoscopically we can destroy this muscular wall, and the patient's condition improve. It's a rare condition. I've seen only few cases of them. Esophageal webs. These are inflammatory constriction, usually in the hypopharynx. This may cause dysphagia. If it is associated with Plummer-Vinson with iron deficiency, we call it Plummer-Vinson syndrome. Treatment by dilatation. These are the esophageal webs. We actually pass a dilator, we destroy these webs, and the symptoms usually or should disappear. Now, Shadsky ring, that's another constriction at the squamous-columnar junction. People believe it's related to reflux disease. However, not the majority of the patients with reflux disease do not develop Shadsky ring. This is a common cause for dysphagia, and it can or the patients may present with food bolus obstruction. Actually, after eating like chicken or meat, it will stuck at the level of the Shadsky ring. How do we treat? We treat it by dilatation. This is how it looks, Shadsky ring. So we pass a dilator to destroy this ring and relieve patients' symptoms. Hiatal hernia. There's two types of hiatal hernia, sliding or paraesophageal hernia. Sliding, so the GE junction and part of the fundus of the stomach lies in the thoracic cavity. And in this type of hernia, patients usually suffer from reflux disease. The other type is paraesophageal hernia. That's part of the stomach is herniated beside the GE junction, which usually remain normally located. The paraesophageal hernia may incarcerate, ulcerate, or cause dysphagia. This is normal. As you can see this is the level of diaphragm, this is the level of diaphragm. So part of the stomach and the GE junction is sitting above the diaphragm in the thoracic cavity. While here, the GE junction normal location, but part of the fundus herniate beside the esophagus above the diaphragm and sits in the thoracic cavity. Mallory-Weiss syndrome. This kind of syndrome preceded by vomiting and retching. So injury of the gastroesophageal junction and tear may occur, and patients present with upper GI bleeding. Most of the cases resolve spontaneously. You can see the tear at the esophageal side at the GE junction, and this is a cause of bleeding. Most of the time, the tear is more towards the gastric side, to be honest. Motility disorders. Now, few words regarding motility disorders. أنا بعرف إنكم بتاخدوا special sessions لما تيجي تداوموا عنا مع الست دعاء والست سوسن. However, بنحكي عنهم بسرعة هنا. We'll talk about achalasia. Achalasia, the lower esophageal sphincter fail to relax. When we swallow, the lower esophageal sphincter opens up to allow the food to enter the stomach. In this condition, there are failure of relaxation of the lower esophageal sphincter. Now, the propulsive movements that we call the peristalsis also fails. So the contractions, they may still there, but they are not peristaltic. So they do not have propulsive power. So why does this happen? Because there is the arrangement and degeneration of inhibitory ganglion cells, neurons at the mesenteric plexus and the esophageal wall. So what happens? The inhibitory neuron degenerate, the excitatory neuron is still there. So the excitatory neuron takes over the function and the lower esophageal sphincter remains contracted. It does not relax because it does not get exposed to the inhibitory tone. Now, the main differential diagnosis is to differentiate achalasia from secondary causes, and in this condition we call it pseudo-achalasia. And the major differential diagnosis is gastric cancer involving the gastroesophageal junction, other infiltrative diseases like amyloid, sarcoid, Chagas disease, eosinophilic esophagitis, and neurofibromatosis. How do these people present? They present with dysphagia over long period of time. They may have chest pain, regurgitation, difficulty in belching, modest weight loss, not like neoplastic disorder, but they may lose a little bit of weight. How do we diagnose them? That's based on the signs and symptoms. We can do a plain chest X-ray. We can do a barium study, and we can actually do motility. So this is the motility disorder. This is a normal swallow. Now, let's look. This area represents the upper esophageal sphincter, and this area here represents the lower esophageal sphincter. As you can see, the blue color reflects low pressure. You can go to reference, that is near 0. So when the sphincter is relaxed, it means we will see some blue color. So both sphincter here are relaxed, which is the normal. Now let's look at the esophageal body. The higher or the color, or the darker the color of the esophageal body, it means that the pressure is higher. Okay. For example, the greenish to yellow, we're talking about 80 to 60 millimeter mercury. So these are contraction, and as you can see, they are propagating towards the end of the esophagus. So the first contraction starts proximal esophagus and then keep moving down until it reaches the lower esophageal sphincter. So these are peristaltic. These are propulsive movements. Now let's look at the achalasia. The upper esophageal sphincter is functioning normally because this is blue color, so there is relaxation. But the lower esophageal sphincter did not relax. This is the area of the lower esophageal sphincter. As you can see, there's still some pressure around 60 millimeter mercury in the lower esophagus. Now, let's look at the contraction. The contraction is simultaneous and slightly weaker than normal. So these are not peristaltic, or we call them aperistaltic contractions, as you can see here. Compare this picture to this picture. You can see a nice propagating contraction of the esophagus while simultaneous contraction in this picture. Now, there is relaxation of the upper esophageal sphincter because this is a skeletal muscle. The lower esophageal sphincter, it should relax like this. It does not relax in this diagram. So this is achalasia, and this is normal food bolus swallow. Now achalasia, 3 types: type 1, type 2, and type 3. So type 1, the contractions or the pressures within the esophagus or the esophageal lumen is low. Okay, and the difference between type 1 and type 2 is the contraction is really strong in the type 2 achalasia. So the pressure within the esophageal lumen is elevated. Now there are type 3, it's similar to type 2, but with spastic contraction at the distal end of the esophagus. Now, this is a barium study, dilated esophagus, bird beak appearance. Okay, this is you can see air fluid level. This is air, this is fluids in the esophagus, and this is vigorous contractions in type 3 achalasia. So this is a chest X-ray, just regular chest X-ray. This is the esophagus sits here. You can see actually whitish color in here and darkish color in here. So this is gas and this is fluid. So that's air fluids level at this area. This is side view. It shows more clearly. This is the trachea. This is the esophagus, air and fluids level. This is bird beak appearance, dilated, wildly dilated esophagus, a hugely dilated esophagus. So we diagnose achalasia by several techniques. X-ray, barium study will show dilated esophagus, bird beak appearance. Motility study, I have shown you the different types of achalasia. And during motility, you will find elevated or resting lower esophageal sphincter pressure. Occasionally, it can be normal, however. Always, you need to have a peristalsis in the body of the esophagus, and the contractions are simultaneous. This is the motility probe. It has a sensor here. You can see the lower esophageal sphincter does not relax, and these are aperistaltic simultaneous contractions, characteristics of achalasia. We usually do endoscopy for these patients. We see dilated esophagus full of food, narrow sphincter with resistance to the passage of endoscope, and it's very important to exclude pseudoachalasia. This is dilated lumen. It contains some fluids here. Most of the time we see more than fluids, we see some food material. How to treat? Our objectiveness is to decrease the lower esophageal sphincter so the food can pass easily into the stomach. So we have to disrupt the smooth muscle fibers at the lower esophageal sphincter. This can be done by pneumatic dilatation or endoscopic balloon dilatation. This is what we do in our unit. A new technique called POEM or myotomy, endoscopic myotomy. It can be done with an endoscope. We are probably going to perform our first case early next week or the end of this week. And we can send the patient to the surgeon so he can cut the fibers from outside surgically. Some medications may help to decrease lower esophageal sphincter pressure, but in general they are left for really very highly risk patients for any endoscopic or surgical intervention, because the efficacy of these medications is quite limited and for a very short period of time. Some authors or some gastroenterologists may do botulinum toxin injection, and as I said, calcium channel blocker and oral nitrates may help. Now, the other motility condition is distal esophageal spasm. These patients present with dysphagia, chest pain, heartburn, again due to impaired inhibitory innervation. Occasionally can be induced by acid exposure. What are these contractions? These are premature. These are simultaneous, rapidly propagating. So they are propagating contraction in the distal esophagus. If you count more than 20% of the swallows on motility with these features, we call it diffuse esophageal spasm. If you perform a barium study, you can see rosary beads or corkscrew appearance. There is a picture actually. I'll show it to you in a moment. How to treat this? You need something to relax these smooth muscles. زيت النعناع, peppermint oil. These are available as tablets. PPI and calcium channel blocker. This is how it looks. Corkscrew or beaded appearance. This is typical corkscrew of diffuse esophageal spasm. Jackhammer esophagus. It's simply not unlike diffuse esophageal spasm, but it's due to excessive excitation and smooth muscle hypertrophy and response to excitatory nerves. They present dysphagia and chest pain. The barium shows normal sequential peristalsis, but the pressure is usually very high. This is a very high pressure waves, but sequential contraction and their arrangements. They're treated by, again, the same regimen: calcium channel blocker, PPI, and peppermint oil. This is how it appear on motility. Very high pressure seen in high resolution manometry. بكفيكم. I'll stop here. I hope انكم فهمتوا. If there is any question, I'm happy to answer. سامعيني؟ هلو.
دكتور سامعين، يعطيك العافية.
دكتور
تفضلي.
دكتور ممكن تعيد الفرق بين أكاليزيا تايب 1 وتايب 2؟ إنه
لحظة شوي، هلا بجيب لك السلايد. I'll show you. This is actually very simple. Just watch the slides. Okay. This is achalasia type 1. كويس. شوفوا الأبر اسفنجيال سفنكتر بيفتح، صح؟ لأنه هذا سكيليتال ماسل ما دخلوا بالأكاليزيا. اتفقنا؟ طيب هلا تحت دكتور. هنا تحت هذا اللور اسفنجيال سفنكتر fail to relax، صح؟ صح؟ صح.
صح.
هلا هنا اللون ضله أزرق، معناته البريشر جوا اللومن اوف اسوفيجاس فيري لو، يعني الكونتراكشن مش قويات. اتفقنا؟ هاي تايب 1. هاي تايب 1. شوفي تايب 2. تايب 2 نفس الاشي، في ريلاكسيشن هنا عند الابر اسفيجيال سفنكتر، ما في ريلاكسيشن هنا عند اللور اسفيجيال سفنكتر، بس شوفوا الكونتراكشنز كيف لونها اصفر، البريشر فيها عالي. فالبريشر بيكون فيها عالي في تايب 2 اكاليزيا. شايفينه كيف؟ هاي هو الفرق اللي بتميز بين تايب 1 وتايب 2. This is very simple.
اوكي تمام، شكرا دكتور.
طيب في شيء تاني او ثالث احكي لكم اياه؟ طيب اذا ما في شيء، thank you for listening. I hope انكم استفدتوا من هذه المحاضرة. Hope to see you face to face in the future. Thank you.
يعطيك العافية.
أهلين.